Hi, this is Andy Buck from EDExam. I'm really excited to be bringing you the first EDExam whiteboard session. It's on Wolff-Parkinson-White atrial fibrillation, which is a common exam topic that crops up and causes people a lot of confusion. So I've constructed a new teaching technique using a digital whiteboard, and I hope you find it useful. If you've got any comments or suggestions or feedback, I've simplified the physiology a bit just to get the learning points across, so we might be able to have some discussion about the intricacies and some of the numbers and physiologic details. So if you've got any comments, please feel free to leave a comment down below on the YouTube page, or send me an email, andy@edexam.com.au, and I really look forward to your feedback, and hopefully we'll be able to bring you more of these sessions soon. The learning objectives for this session are to understand the pathophysiology of atrial fibrillation and Wolff-Parkinson-White syndrome, to recognise the Wolff-Parkinson-White and atrial fibrillation ECG, and to implement the correct therapy for this potentially life-threatening condition. We'll start by discussing the normal physiology of the conducting system of the heart. In a normal heart, impulses travel from the SA node through the atrial internodal tracts to the AV node. They then pass through the AV node to the bundle of His, to the right bundle branch, and the left bundle branch, which has an anterior and posterior fascicles. The AV node is the gatekeeper to the ventricles and is rate limited. Due to its refractory period and a phenomenon known as decremental conduction, it actually slows its own conduction the more frequently it is stimulated. It can only pass impulses at a maximum of around 200 beats per minute. Of course, there's some individual variation in this, and you can get higher sinus rhythm rates, especially in children. If you think of the fastest sinus tachycardia you've seen in an adult recently, it's rare to see someone, even in severe shock, with a heart rate greater than about 170 or 180 beats per minute. So in atrial fibrillation, when the atria are contracting at around 300 beats per minute, the AV node serves to protect the ventricles from firing with one-to-one conduction. And again, this is why you rarely see AF rates higher than 160 or 170 beats per minute, because the impulses are being slowed down by the AV node. Decremental conduction would also explain why you can see SVTs going at around 200 to 220 beats per minute, with every impulse being transmitted through the AV node. But once you crank that rate up to around the 300 mark in atrial fibrillation, the AV node can't handle that rate of conduction, and it'll start slowing the conduction down. Hence the fact that patients with atrial fibrillation usually have slower rates than patients with SVT. People with Wolff-Parkinson-White, however, have accessory internodal tracts called the bundle of Kent. Often there is only one, but it has been documented that patients can have up to 8 separate accessory tracts. These accessory pathways are not rate limited like the AV node and can pass impulses from the atria to the ventricles in a one-to-one fashion. In sinus rhythm, these patients their conduction goes via the AV node and the accessory pathway at the same time. The accessory pathway doesn't slow the impulses, therefore its impulses arrive first, causing the characteristic delta wave on the ECG. So the way this is manifest on the ECG is we have the P wave, PR interval, and the delta wave is caused by the impulse that has travelled through the accessory pathway arriving in the ventricles first, and shortly thereafter the impulse that's passed via the AV node will arrive. So depolarization will start from this impulse and then be quickly caught up by the second impulse. So you'll see the delta wave from the first impulse, then the normal QRS will take off after that. So the delta wave is from this bit of conduction. Interestingly, most people who have Wolff-Parkinson-White syndrome are asymptomatic and don't know that they've got it. If they go into atrial fibrillation, however, they'll have an atrial rate of about 300 beats per minute. If this impulse are passed first down the accessory pathway in a one-to-one conduction fashion, they'll go into VF. This is what's known as manifest Wolff-Parkinson-White syndrome and is the cause of sudden cardiac death in these patients. Fortunately, this is a rare occurrence. Most patients with Wolff-Parkinson-White syndrome, even when they go into AF, their main run of impulses will go through the AV node and they'll have what's called concealed Wolff-Parkinson-White. It's fairly easy to see now then why patients with atrial fibrillation or Wolff-Parkinson-White syndrome who arrive in the emergency department must by definition have concealed Wolff-Parkinson-White because they haven't dropped dead from their sudden cardiac death outside of the hospital. However, you need to be really careful when treating these patients because if you give them an AV nodal blocking drug, you'll then force all of the impulses from their atrial fibrillation through the accessory pathway into the ventricle and put them into VF. It's worth mentioning at this point the combination of Wolff-Parkinson-White syndrome and supraventricular tachycardia or SVT. In this case, you'll have a regular narrow complex or possibly broad complex tachycardia. Even if the patient has this with Wolff-Parkinson-White syndrome, they'll have a trigger focus in the atria and their impulses will either be travelling through the AV node, back up the accessory pathway, back to the atria and starting a circus movement, or it'll travel the other way through the accessory pathway, back up through the AV node, back to the atria and continuing. And these are called orthodromic and antidromic conduction. If you were to treat these patients with an AV nodal blocking drug, all you do in this situation is interrupt this circuit. And it doesn't matter which way the impulse is travelling, blocking it from one side or the other doesn't really matter because you're interrupting the circuit and you'll terminate the arrhythmia. This is quite different from atrial fibrillation when impulses are being bombarded at either the accessory pathway or the AV node at 300 beats per minute. And if the AV node is blocked, you force 300 beats per minute down the accessory pathway and put the patient into VF. So to be clear, it's quite safe to give patients with Wolff-Parkinson-White syndrome and SVT AV nodal blocking drugs because all you're doing is putting a roadblock into a circuit and terminating the arrhythmia. This is a quick show of the Wolff-Parkinson-White and atrial fibrillation ECG. It's a bit of a classic to show up in exams. It showed up in my fellowship exam actually, and it's a bit of a spot diagnosis. There's not many other things, or there are no other conditions that cause this particular ECG appearance. What it causes is an irregular, if you map it out, see the rhythm here is quite irregular, broad complex. If you look at the QRS complexes, generally broad, chaotic looking tachycardia. And you can see the complexes vary in amplitude and width, and the rhythm's quite irregular, and it's just a generally chaotic, large, complex looking ECG. Another thing you'll sometimes see is these slurred up strokes on the QRS complexes. All of these things together combine to make this a spot diagnosis ECG of Wolff-Parkinson-White and atrial fibrillation. So you can see now that blocking the AV node in patients with atrial fibrillation and Wolff-Parkinson-White syndrome is a bad thing to do. This means that all of the standard drugs you give to someone normally in AF or SVT are contraindicated. These include adenosine, beta blockers, calcium channel blockers, digoxin, and even lignocaine. And the reason, as we've already discussed, is that if you block the AV node in these patients and they're in AF, you'll force 300 beats a minute into the ventricles and put the patient into VF, which can have terminal consequences for a patient in your emergency department. So the same principles of treatment apply in Wolff-Parkinson-White and AF as with any other tachyarrhythmia, and that is that if the patient's unstable, the definitive treatment is DC reversion. I would start at 100 joules biphasic, incrementally moving up to 200 joules biphasic. If the patient's stable, however, the American Heart Association 2011 guidelines on the management of AF and WPW suggests that you can try amiodarone, flecainide, or procainamide. However, this last one's not available in Australia. Some people are a bit nervous about giving amiodarone to patients in this situation because it has multiple class effects as an antiarrhythmic, and some people feel that its potential risk of blocking the AV node outweighs its potential benefits. Flecainide also has some unique restrictions on it in that it's better in patients who have no cardiomyopathy or a structurally normal heart and who are younger. Personally, if I was faced with a patient in AF who had Wolff-Parkinson-White syndrome, the safest option is to go with DC reversion. If for whatever reason you feel it's not appropriate to proceed with that, I'd seek expert cardiologic and electrophysiologic advice before I went and treated the patient with any of these medications, because they all have some unique properties that you may not be aware of and you need to know about. Of course, once you've stabilised the patient, they've reverted back to sinus rhythm, the definitive management is to refer to a cardiologist for electrophysiologic studies, and the definitive preventive treatment is radiofrequency ablation. So there you have it. In summary, Wolff-Parkinson-White atrial fibrillation is a condition that's associated with sudden cardiac death. However, this is a fortunately quite rare occurrence in these patients. It's worthwhile noting that these sudden cardiac deaths can be spontaneous in patients with manifest Wolff-Parkinson-White syndrome, but it can also be iatrogenic if the condition and particular ECG for this condition is not recognised and any of the contraindicated medications are given, which will block the AV node, forcing all of the impulses down the accessory pathway and putting the patient into VF. The contraindicated drugs include adenosine, beta blockers, calcium channel blockers, digoxin, and lignocaine. So if you're ever faced with one of these patients and you pick it on the ECG and you're going to proceed with some treatment, if there's any doubt in your mind, the safest option is to DC revert them. And I'd seek expert cardiology advice before I proceeded with any drug treatment.